Thank you for the opportunity to present this morning. The title of my talk is Eosinophilic Gastrointestinal Diseases 2024, Single Topic Symposium, Insights Gained from the Participant Survey. In 2024, coincident with the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition annual meeting, that was held in early November down in Hollywood, Florida. There was a single topic symposium that focused on eosinophilic gastrointestinal diseases, or EGIDs. And the purpose of the symposium was to review current state of the art in therapy and diagnostic techniques for EGID care. The course was developed by co-directors Rajitha Venkatesh, who's at Nationwide Children's Hospital, and James Franciosi, who at the time was in Orlando and has since moved to Louisville University School of Medicine. The objectives of the symposium were to review EGID history and pathogenesis. I should say the symposium was broken up into several modules. Next were innovations and advances in monitoring EGID disease, advances in EOE therapy, advances in non-EOE EGID therapy, and I'll get to the distinction between EOE and non-EOE EGIDs in a minute, and advances in patient care for EGIDs. So what are EGIDs? EGIDs are eosinophilic gastrointestinal diseases, and they are diagnosed by counting the peak number of eosinophils seen in a collection of pinch biopsy tissues that are taken during an endoscopy procedure. So these pinch biopsies are processed by pathology, and the number of eosinophils per high-powered microscope field are counted. And as you can see on the right, EGIDs can occur anywhere within the gastrointestinal tract. Today, what we're going to focus on are EGIDs that occur in the esophagus because of time limitations. And these are defined as conditions in which there are greater than or equal to 15 eosinophils per high-powered microscope field in the pinch biopsy collection. So what were during the single topic symposium, there was a survey that the directors had created and made available to all attendees of the single topic symposium. And the objectives of the survey, it was hosted in REDCap. The objectives of the survey were to evaluate the state of healthcare for EGIDs, compare utilization of modern technologies and clinical and therapeutic approaches for the care and treatment of EGIDs across different practice types, and identify unmet needs in the care and treatment of EGIDs. So this was the structure of the survey. It had roughly 10 different domains. The first domain, demographics, was available to everyone who participated in the survey, regardless of what their current career responsibilities were. And then the other domains were available only to attending physicians. And so there were 40 main questions in the unconditional survey, and then depending on how these questions were answered, there were the potential for an additional 23 items for a total of 63 items total. So first beginning, looking at the response rate by attendee category, I'll draw your attention to the second from the bottom line. Since we're primarily focused on attending physicians for this particular survey, you can see that of the 205 respondents, 167 of them identified as attending physicians, and the response rate among them was 57%, which is pretty good for these kinds of surveys. Looking at the group characteristics, the first column, the first numeric column is all attending physicians grouped together. And then the next two columns are attending physicians from academic centers, AAPs, and attending physicians from clinical hospitals and private practices, designated as CAPs. So the first thing to notice of significance is that the median years that these attending physicians had been in practice was about 11 for everyone grouped together. And when you look at the categories in which they self-stratify as either academic or community and private, you can see that the median number of years for community hospital attending physicians was 5 years greater than for the academic physicians. The geographic regions of the United States were roughly equivalently represented among the three groups. And we did have a few from Canada as well. In terms of academic rank, not surprisingly, it's significantly different between the academic center and the community hospital. There was a slight increase in the number of associate professors at community centers relative to the academic centers, which may mean that as they get later in their career, they tend to transition to private practice. In terms of the academic activity, again, not surprisingly, there was a significant difference between the two groups on the right, with the majority of attending physicians at academic centers responsible for mentoring learners at any level. And roughly 73% are engaged in some sort of active EGID research, relative to 18% that are in private practice and community hospitals. And in terms of residents and fellows, you can see that there are many more residents and fellows available to attending physicians at academic centers relative to community hospitals. So it's a function of training, and also a function of being able to have help to conduct research projects. Regarding the number of EGID patients seen, you can see that in general, it's fairly well divided between the different categories over here on the left, with the academic centers having slightly more physicians who see patients in the 16 to greater than 20 per category per month relative to the community centers, which is not surprising. People tend to go to where the expertise is, at least, based on what they find in their research. Okay, and then if we look at the treatment preferences, there are three main frontline therapies for EGIDs, and up until 2022, all of these three main therapies were given off-label because there was no FDA approval for any of these for eosinophilic esophagitis. First is the high-dose PPI, and the PPI is not therapeutic because of its gastric acid inhibition properties. It's therapeutic for an off-target mechanism that involves an anti-inflammatory response in the patients that receive this. Topical solid steroids, of course, are anti-inflammatory. And then the next major frontline therapy had been dietary elimination. So EOE is a disease in which the body has an inappropriate response to food antigens. If you can identify those antigens and remove them from the diet, then those elimination diets can be quite effective. So looking at the preference of physicians for these different therapies, based on the current number of patients for which they have placed on these different therapies, you can see that roughly 54% of academic physicians infrequently use PPIs, relative to 35% that infrequently use solid steroids, 71% that infrequently use dupilumab. Dupilumab is a biologic that has recently been developed to treat EOE. And roughly 56% infrequently used dietary elimination. Allergy-based elimination is not preferred by the majority of physicians, 85% of them, primarily because it's been shown not to be very effective. So if you identify if you identify allergens based on skin prick testing, it does not tend to translate well into a therapy that works for eosinophilic esophagitis. Regarding the differences between the categories, there is some slight difference in the preference of steroid use among community physicians and academic physicians, with a greater fraction of the community physicians relying almost entirely on swallow steroids relative to the academic physicians. The rest of the categories aren't terribly different until we get to dietary elimination, where again, the dietary elimination is more preferred in the community setting relative to academic setting. The dietary elimination can be beneficial for families who want to avoid long-term therapy, because EOE is a condition where people need to be on a therapy for the lifetime, essentially. So if they can find a dietary elimination therapy that doesn't disrupt their quality of life too much, for a number of families, this can be a preferred choice. Okay. So if we then look at this data in a different way and we sum up the categories for physicians who have greater than equal to 10% of their current patients on a particular therapy, and we look at it this way, we can see that the overall preference is for topical corticosteroids, swallow topical corticosteroids, followed by any elimination diet, and then high-dose proton pump inhibitors and the new biologic. And then if you look at the stratified data, you can see that there may be a difference in preference between high-dose proton pump inhibitors, who fall to the bottom of the list, and the new biologics. Okay, so let's move on to disease monitoring technologies, and first we'll review what the technologies that are currently available are. The mainstay of the gastroenterologist is the esophagogastroduodenoscopy, or EGD, with biopsies. It's a relatively large caliber tube, which is inserted through the mouth and down into the esophagus under general anesthetic. It's, as I said, it's a mainstay of the gastroenterologist, but it does have some drawbacks in that it requires a general anesthetic. The patient has to be, has to allow time to recover before they can, begin their normal activities again. This is the kind of data that you get. The endoscope has a camera on it, in addition to be able to put a hemostat on the end of it so you can grab tissue bits. This is what the data looks like. So this is from, these pictures are from EOE patients. On the left, you see the characteristic rings of fibrostenosis. In the center, you see the longitudinal furrows, and then on the right are the white inflammatory exudates. The next new technology is called endoluminal functional lumen imaging probe. This is what the instrument looks like. And this involves inserting a gas-filled balloon catheter into the esophagus. The catheter has roughly 16 different sensors within the balloon space. These sensors measure pressure, temperature, and diameter within the esophagus, and you get a data output similar to what you see on the right, where you can see the narrowing regions due to strictures from fibrostenosis in EOE. So this gives them a sort of a topographic image of what the inside of the esophagus looks like. The next is a transnasal endoscopy, and this is similar to the EGD, except that it uses a much smaller caliber probe. The probe can be inserted through the nose and then down into the esophagus. And all that's necessary is a local anesthetic, a lidocaine spray, so that the patient can be up and moving around, essentially as soon as the procedure is finished, which is great, for a young kid who wants to get back to their sports activities in the afternoon. You can collect the same kind of data with a T&E that you get from an EGD. So again, we've got a normal esophagus on the left, and then we've got center has exudates and edema and linear furrows, and then on the right, it's more severe disease with exudates and edema and linear furrows. You can take pinch biopsies with T&E as well. So it really is an advance. It improves the quality of life for the patient, and it's easier and much cheaper as well, since you don't have to have a general anesthetic. Next is a technology called string test. String test is just a simple nylon string that's wound up in a gelatin capsule. The tag end is taped to the patient's face. They swallow the capsule dissolves, and the nylon string deploys in the esophagus. Mucus of the esophagus attaches to the string, and then an hour later, the string is removed, and the proteins in the mucus are analyzed by ELISA. They're looking specifically for eosinophil-associated proteins. Depending on their levels, it's an indication of the EGID disease state in the esophagus. And the next, the final one, is a cytosponge test, which was originally developed for cancer diagnosis of esophageal cancer. It's a nylon sponge that's, again, encased in a gelatin capsule. The capsule swallowed, dissolves, and then the sponge is withdrawn from the esophagus. And on the way out, it collects sheets of cells that are analyzed by pathologists to do eosinophil counts and so on. So regarding the use of these advanced disease monitoring technologies, if we look at all attending physicians, we see that roughly 50% of them do not have the technology available to them, or they don't use it. Roughly 29% use it on 0 to 5 patients per month, and then roughly 13% use it on greater than 5 patients per month. Now, the situation is very different if we look at the stratified data. Attending physicians from academic centers, the not available rate is much lower. It's about 39%. And you see greater fractions of them using the technology on their patients. If you compare that to community centers, you can see that roughly 88% of physicians from the community centers report that they either don't use it or it's not available to them. The situation gets even worse when you go to T&E, where roughly 97% of the physicians at community centers report that it's not available. The only person who abstains from that count is the person who is unsure whether or not the center has the technology, and none of them use that technology on their patients. Whereas if you come over to the academic centers, roughly 25% use it on between 0 and 5 patients per month, and greater than roughly 24% use it on greater than 5 per month. You can see that string and sponge technologies are largely unused by most attending physicians, primarily because the technologies are new and still need to be proven. Okay, in terms of unmet needs, there was a question asked about what the attending physicians felt were the unmet needs in the clinical medicine for EGIDs, and this particular question was specific to EOE. What I've done here is I've tried to group responses together based on similarity in theme. So I could have introduced some bias in this grouping. But based on this grouping, the top response was that they're looking for improved therapeutic and diagnostic guidelines. So they really want more guidance for how to treat these patients. They want more therapeutics and treatment options. They want them to be approved by the FDA so they don't have to treat patients off-label. They want improved non-invasive diagnostic monitoring, diagnostics and monitoring techniques. And they want guidance for how to personalize care for these individuals with biomarkers that are predictive, improved insurance coverage, and also they were concerned about there's a lack of guidance for how to wean patients off of the new biologic after the patients have achieved remission of disease. Looking at this data in a slightly less biased format, you can see that one of the primary themes that comes out is insurance coverage, oral medication. So they want to, so the biologics are injectable at this point in time. The holy grail would be to have an oral biologic and non-invasive biomarkers. So in summary, we observed a high level of survey participation by attending physicians, 57%. 73% of attending physicians reported seeing greater than 5 EOE patients per month. The career focus among attending physicians was 40% clinical, 26% clinical research, and only 2% basic science. Attending physicians' preference for primary therapies were topical corticosteroids, any elimination diet, high-dose proton pump inhibitors, and biologics. Acknowledgements, the planning committee. This is the planning committee, so I'd like to acknowledge their significant effort in making this symposium happen. And that's all I have today. I'll be happy to take any questions that you might have.